The following podcast is part of a certified educational activity titled Forging New Paths with Earlier Use of ADCs in Breast Cancer, From Clinical Breakthroughs to Improved Outcomes. Access the entire activity and complete the post-test at peerview.com/PTK860. Downloadable slides and practice aids are also available.
Hi, good evening, everybody. Thanks, and welcome to our evening program today. It's going to be a very interesting one. It's called Forging New Paths with Earlier Use of ADCs in Breast Cancer, From Clinical Breakthroughs to Improved Outcomes. Thanks to PeerView for getting us all together tonight. The symposium is provided by PeerView. Of course, it is a CME program that we'll be going over here tonight. And here's our wonderful faculty. We're really blessed to have a lot of the folks that have done a lot of the work in this area. Professor Sibylle Leubel, who is head of GBG at the University Hospital of Goethe University in Frankfurt. We have Javi Cortez, head of International Breast Center in Barcelona and IOB Institute of Oncology in Madrid, and Paolo Tarantino, an advanced fellow, breast oncology, Dana-Farber Harvard Medical School. Very, very good to be here with you all tonight and learn from you. And we've partnered with GRASP for this program. GRASP is a patient-led organization that connects and empowers patients, clinicians, and researchers to exchange ideas and learn from each other. It also believes in equity, inclusivity, and the power of science. It's committed to fostering inclusive partnerships and addressing disparities that impact cancer research and access to treatment. Learn more by viewing the downloadable resources and visiting graspcancer.org. So thank you to GRASP for your partnership. So our goals for today: we'll learn the latest evidence on HER2 and TROP2 targeting ADCs, which factors to consider in selection of patients and sequencing of ADCs in metastatic disease. We'll also talk about early breast cancer, how to maximize the benefits and minimize the toxicities of ADCs. I'm going to just give a couple of basic introduction slides. I think we're all very familiar with antibody drug conjugates. You need a target on the cancer. We'd like it to be differentially expressed in the cancer compared to normal tissue. There's an increasing number of these. We need a wide variety of payloads, cytotoxic agents, and in the future, VEGF, other immunologic agents. We want bispecifics, but right now it's cytotoxic therapies. We need a wide variety of them. We need high affinity antibodies with long half-lives, again, with selectivity for the target on the tumor. And then we need a linker that's stable in the blood, but that's also cleavable at the tumor site so that then the payload can diffuse to the neighboring cell and kill it as well by the bystander effect. And this, we had our first ADC approved and available for us in 2013. It was TDM1 in pretreated HER2-positive breast cancer, and you can see the timeline, and you can see the ADCs became available as TDM1 moved up into the earlier stage settings, and then, of course, into the curative setting. TDXD and SG came next, sacituzumab govitecan, trastuzumab deruxtecan, initially, of course, in pre-treated patients, and as time goes on, they have expanded their utility into multiple breast cancer subtypes and became used earlier in the treatment of breast cancer. And our most recent approval and access to datopotamab deruxtecan. And we'll hear about all of these agents tonight. And this is really an explosively growing field, as we're all well aware. And this is a summary. These tables change very, very rapidly. This summarizes the first line, the neoadjuvant and the adjuvant ADC trials. The orange is HER2 positive, the green is triple negative, and the red is HR positive, HER2 negative. We're going to hear about all of these tonight that we have data for. But this just shows you this, and this is growing every few weeks. This has to be updated. There's really quite a lot going on. So it's a pleasure now to turn us over to Sibylle, who has been very involved in many of these trials, and to talk to us about HER2-positive breast cancer.
Thank you, Joyce, for this nice introduction and good overview of what ADCs do, what is the mechanism of action, also the time span. We have, since 12 years, we are dealing with ADCs. So the road not yet traveled, we'll see what we are going to travel after we have heard the data on HER2-positive early and metastatic breast cancer. So this is the outcome in metastatic breast cancer, and as you can see, the introduction of T-DXd starting from third line over second line to the front line treatment really has improved the outcome overall, and we will see when we are looking over the general overall survival of our HER2-positive breast cancer patients, if we really can extend that with another couple of years and slowly turn it into a chronic disease. So we are now with T-DXd about in a 40-month median PFS. Overall survival is not yet presented. And we have seen the HER-CLIMB data at this meeting, which will also add another strategy, which we are not talking about. So it all started with the Emilia trial, which compared TDM1 with treatment of physician's choice, lapatinib and capecitabine, and it clearly showed that with TDM1, the IDF, the progression-free survival in this setting could be improved by about 45%. But this was not enough. On the right side, you see the results of the DESTINY-Breast03 study, which really challenged this concept, and again really showed data, surprising data, that with T-DXd, the progression-free survival could be improved by 70%, and you see the huge gap between T-DXd and TDM1, and of course fewer patients had a primary progression. It also shows a trend, clear trend for an improved overall survival, shown below, and that's what we actually want to achieve. So can we further improve the outcomes beyond the current first-line standard of the Cleopatra trial, which was actually established many years ago? And the median progression-free survival in the Cleopatra study, comparing a taxane in combination with pertuzumab and trastuzumab to the taxane and trastuzumab placebo alone. And here the median PFS in the THP arm was 18.7 months. Overall survival could also be improved and showed an almost 5-year overall survival with the introduction of pertuzumab to trastuzumab and docetaxel. The DESTINY-Breast09 study actually built on these Cleopatra data and of course built on the previous data, mainly from the DESTINY-Breast03 study, and enrolled patients with HER2-positive metastatic breast cancer, and also allowed patients with asymptomatic or inactive brain metastases to be enrolled. The disease-free interval had to be larger than 6 months from the last chemotherapy or HER2 targeting therapy in the neoadjuvant and adjuvant setting. So these were not the really very short relapses. And 1 prior line of endocrine treatment for metastatic breast cancer was permitted, but no other systemic treatment in the metastatic setting. This is important. And then it compared T-DXd plus placebo, T-DXd plus pertuzumab, and THP. And the primary endpoint was the progression-free survival. And this is the primary endpoint for the arms T-DXd plus pertuzumab versus THP, because the T-DXd alone arm is still blinded. And I think this is important. And maybe inform you about something else. Concurrent use of endocrine therapy was allowed for those patients with hormone receptor positive disease, and after 6 cycles of T-DXd or discontinuation of the taxane in the THP arm. I think this is important because I think the endocrine treatment is still an integral component of HER2 positive, hormone receptor positive disease. So this is the primary endpoint, the progression-free survival it could again be improved by another 46% roughly, and at 2 years, 70% in the TDXD arm were free of progression compared to 52% in the control arm. Looking at the median in this study, we see that the median with a TDXD is 40 months, and we need to be reminded that many patients were still on treatment in this setting, and the THP arm was 26.9 months, so longer than in the Cleopatra study, which could has something to do with the type of patients enrolled in this trial. We had 50% of the patients with primary, with de novo metastatic disease. Additional endpoints like overall response rate was also clearly improved. Interestingly, the partial response was identical between the two arms, but the complete response was almost doubled with TDXD compared to THP, and overall the response rate is over 85% in the TDXD arm compared to 76.8% in the THP arm. The median duration of response, as expected if the PFS is better, was longer with TDXD plus P, and overall survival had only at this analysis a 16% maturity, and we have the feeling that the curves just start to separate after about 2.5 years. So PI3 kinase is a very important marker of resistance, and this was elegantly elaborated in the Cleopatra trial. And you can see here on the left side where we have the circle. You see here the drop in the blue curves. These are the patients with a mutation in the PI3 kinase status, and here in the circles you clearly see that the median progression-free survival in the PI3 kinase mutant cohort is shorter in both arms, so it's not a predictive factor, but it's a prognostic factor and indicates a worse prognosis. And here is the hazard ratio for the PI3 kinase wild-type population. So we also looked in the DESTINY-Breast09 study into different subgroups, and one was the subgroup of PI3 kinase mutation as a marker of resistance. So let's start from the right side here. This is the PI3 kinase mutant compared to the PI3 kinase wild-type or non-detected group. And as you can see here, the median PFS in the mutant group was 30 months versus 18 months in the with THP, and it was in the non-detected longer as expected, with 40.7 months in the TDXD plus P group compared to 32.7 months. So this is a clear signal. It's working regardless of the PI3 kinase mutation status, as we have seen in the Cleopatra trial, and demonstrates again that PI3 kinase is a marker of resistance and bad prognosis. Similar results in the middle by hormone receptor status. TDXD works regardless of the hormone receptor status, and in both groups TDXD significantly improved the outcome, TDXD plus P to be correct, the outcome in this setting. On the left side, we have the de novo versus metastatic breast cancer patient, and in generally we know that the de novo metastatic breast cancer patients have in general a better outcome, and this we can see here as well. And here TDXD shows the same, if not a larger benefit than in the recurrent metastatic breast cancer group. So it works regardless and in all subgroups. But what about the safety? I mean, a new drug has new safety. We heard in the first study that the ILD is an issue. Patients were dying from that. And so we have a closer look here because patients now receive the drug for a much longer time than in the advanced metastatic setting. The main toxicity is here on the left side, T-DXd plus P, you keep that in mind, is nausea and vomiting, and we recommend today 2 or better a 3 regimen, anti-emetic regimen to prevent nausea and vomiting, which is bothering the patients a lot. Diarrhea is 56%. But this has something to do, of course, with pertuzumab and is equal in both arms. Neutropenia is also a side effect, but not more common than in the arm with THP. And I think all other side effects are equal from what we have known from other metastatic breast cancer trials. Sensory neuropathy is lower than expected, and docetaxel, the taxanes we know, make a lot of sensory neuropathies. But have a look at the ILD. This is the educated drug-related ILD/pneumonitis. This was not differentiated in this study in contrast to the DB05. And we see here that 2 patients died from ILD in the T-DXd arm, but mainly we observe grade 1 and 2 ILDs, and this is grade 1, keep in mind, is the symptomatic, the first symptoms, and in THP we didn't see much of ILD. The heart dysfunction, the left ventricular dysfunction shown below, again, did not show any big difference between the 2 arms. It was any grade 11 versus 7%, and they were mainly grade 1 or 2. So the DESTINY-Breast07, it's a small study, phase 1b, comparing actually additions of T-DXd versus T-DXd monotherapy. So one arm is T-DXd plus durvalumab, but we are not talking about that today. We are talking about T-DXd plus pertuzumab, because the question is, do we need pertuzumab? We are still awaiting the single arm from DESTINY-Breast09. We might get some hints, but probably not an answer what is the real effect of pertuzumab in this setting. And these patients were similar to what we have just seen. They had to have measurable disease and could have brain metastases. But these have to be stable, and there should be no prior treatment for metastatic breast cancer. So this is the response rate in the median progression-free survival. So the response is actually slightly increased with the addition of pertuzumab by 84% versus 77%. So this is an added value of pertuzumab. The overlapping curves in the PFS do not really help us, because the study is just too small to give a definitive answer here, but the median is more or less the same. So we need to await the final results of the DESTINY-Breast09 study to derive a final conclusion. So DESTINY-Breast012 study was a very elegant study in patients with brain metastasis. It was a single-arm study in patients with either brain metastasis or no brain metastasis, and just all patients received T-DXd. With enthusiasm, this study was very well and very quickly recruited. The overall population had 263 patients. Stable brain metastasis had 157 patients, active 106 patients. And as you can see here, the response rate is very good, and depends a little bit, of course, of the pre-treatment. It was best with over 80%, 83% in the untreated, previously untreated group, but it was still 79 and 63% in the stable and active brain metastasis respectively. So the median PFS in the group with the or the overall survival in the patients with brain metastasis at 1 year was 90%, and this was very comparable to the patients who did not have brain metastasis at baseline, suggesting that T-DXd works in the brain metastasis. And if you want to know more about patients with brain metastasis, I recommend to look at the educational session from yesterday lunchtime, because there was one talk about brain metastasis and ADCs in brain metastasis. So what about ADCs in early breast cancer? Here we have a summary of the data I've just shown you, but what about early breast cancer? And we have seen those data several years back. This is the Catherine trial, and this actually shifted the paradigm in HER2-positive early breast cancer. It was the first study actually taking non-PCR patients and conducting a study or a treatment effect exclusively in this. And all patients in the Catherine study just had to have residual invasive disease, regardless of the size, regardless of nodal involvement, and regardless of the size of the tumor at baseline. And then the patients were randomized to trastuzumab as the standard of care, or T-DM1. And T-DM1 at that time reduced the risk of recurrence by half. So, and the absolute improvement was 11% from 77 to 88% in the first interim analysis at 3 years. 2 years back, we presented the data of the final overall survival analysis at this meeting, and it's now published in the New England Journal of Medicine, because the difference held true. The updated IDFS you see here, it's still at 7 years the same difference, the same hazard ratio or comparable hazard ratio, and the overall survival, which is the most important for our patients, could also be improved by using T-DM1 in non-PCR patients instead of trastuzumab with a hazard ratio of 0.64. But the open question still remained. Can we do better in high-risk patients? High risk of recurrence, patients with nodal involvement after neoadjuvant therapy. We know node-positive disease is the strongest prognostic factor after neoadjuvant treatment. In Catherine, the 7-year IDFS was 72%. And in patients who had inoperable disease at baseline, also they had a considerable risk with 67% being having an IDFS-free survival rate of 67%. Can we do also better in the IHC2 plus patients? Because in Catherine, in the subgroup analysis, we did not see a big difference for the IHC2 plus patients between T-DM1 and trastuzumab. And can we do better in preventing brain metastasis? Because in the Catherine study, we saw 7% in the T-DM1 arm versus 5% in the trastuzumab arm. So this is the stage when the study was designed. We didn't know the 7-year data at that time. We just knew the 3-year data. So the Destiny Breast 05 study was only the logical consequence of those thoughts, that there is still a population which has a high unmet medical need, and they simply took similar inclusion criteria but at a higher level. So patients had a high risk, and this was defined as inoperable breast cancer at baseline or node-positive disease after neoadjuvant treatment. And those patients, it's about 50 to 40% of the original Catherine population, were randomized to T-DXd now or T-DM1, again given for 14 cycles, as this was the treatment standard established in the Catherine study. And the primary endpoint was invasive disease-free survival. The primary endpoint demonstrated in the presidential session at this year's ESMO meeting just less than 2 months ago demonstrated another 50% plus improvement in the iADFS rate compared to TDM1 and an absolute difference of 8.7% at interim analysis. So this is really another quantum leap forward in this high-risk population. Secondary endpoint, distant relapse-free interval, brain metastasis-free interval, and overall survival are still immature, many of them, but they are trending into the right direction. The distant relapse-free interval had the same hazard ratio with 86% versus 93.9%. So we are getting closer and closer to the 100%, and we discussed that already before the meeting. Safety, of course, in early breast cancer, we have to even do a more sincere risk-benefit analysis, but what we don't want to, that patients are dying from a very effective treatment, which but they did not tolerate. And here we can again see the main side effects are nausea and vomiting. All other side effects are as expected, and also in the TDM1 arm. We have outlined here again the ILD pneumonitis and the left ventricular dysfunction. Again, 2 patients in the trial were dying of the ILD, but otherwise mainly grade 1 and 2 in this study, and the left ventricular dysfunction is shown here, and it was also mainly grade 1 and 2 in this study. And it was not actually interfered by the adjuvant radiotherapy, the timing, sequential or concurrent, and I will show you the data in more detail which I had presented yesterday in the rapid fire presentation. So this was actually the protocol, what you had to do, the CT requirements for identifying ILD or radiation pneumonitis, and all patients got it at baseline or after radiotherapy. And then when you started the treatment, the first CT scan was after 6 weeks of treatment, and then every 4 cycles, and the last CT scan was 40 days after the patient completed treatment or stopped the treatment. So in any signs or symptoms of radiation-induced pneumonitis or drug-related ILD appear, of course, additional CT scans were recommended. These are the treatment management guidelines for drug-related ILD in the clinical trial protocol and pneumonitis. And what is clear, grade 3 and 4, these patients have to stop the treatment for radiation pneumonitis if that can clearly be attributed or identified as radiation pneumonitis. Grade 2 can after interrupting the treatment and recovering, they can continue, and in grade 1 there was nothing to be done, which is slightly different from the ILD, where you stop the treatment and apply steroids until the patient has recovered, and you stop certainly also already in grade 2. This is a slight difference if you are sure that it's a radiation pneumonitis or an ILD. So did the radiotherapy timing in relation to the TDXD or TDM1 treatment affect the ILD and the radiation pneumonitis? Here, these are the ILD data. We saw 7% of ILD versus 1.6% in the TDM1 arm. The timing of adjuvant radiotherapy actually did not impact the incidence or the severity of ILD in either arm. And in the TDXD arm, the adjuvant radiotherapy timing had no effect on the time of onset or duration, shown here in the lower lines, time of onset is similar, and a duration is also similar in both arms. There's a slight difference here. Time of onset is shorter in the sequential arm in TDM1. In Catherine, we didn't look that specifically. That's why the rate is lower, and we didn't have those data. So most patients with drug-related ILD actually had recovered at the data cutoff. About investigator-reported radiation pneumonitis, here we have an equal all-grade incidence in both arms, about 30%, and in both arms they were mainly grade 2 or lower, but there was really no big difference between sequential concurrent. There was a slight increase in the sequential arm. Most patients with radiation pneumonitis recovered, but though the rate of patients who did not recover with the sequential radiotherapy was higher in the TDXD compared to the TDM1, and was 55 versus 40%. And in the TDXD arm, the patients receiving sequential adjuvant radiotherapy showed a longer time to onset and duration. You can see that here, longer time to onset and longer time of duration of the radiation pneumonitis than in the concurrent arm. So if you are interested to read the complete paper, I invite you to do that. It's online since yesterday. So in the neoadjuvant setting, we also saw very interesting data, but we shouldn't forget that we also had a neoadjuvant study, the Christine study, and there was another study which looked at the tumor heterogeneity, but I'm not going into that detail. But what we saw here was that the TDM1 plus pertuzumab compared to T-carbo-HP was not superior. Actually, TDM1 plus P resulted in a lower PCR rate, but what we always see, hormone receptor positive, HER2 positive disease results in a lower PCR rate than the control. And on the right side, you see the event-free survival is different, but the IDFS is not, and the reason is that we see more local regional progressions in the TDM1 arm, which was 15, it was 6.7%, and this was the difference in the event-free survival because this counts as an event. So the Destiny Breast 11 study is the neoadjuvant study conducted with TDXD followed by THP, both given for 4 cycles. The control arm was dose-dense AC without anti-HER2 treatment, followed by THP, and the last arm was 8 cycles of TDXD, and this arm was closed because of the recommendation by the IDMC of a lower PCR rate, etc. The primary endpoint is PCR in this study. And these are the PCR rates in all 3 groups. Again, the overall population on the left side, and then the split by hormone receptor status. We have a higher PCR rate in the TDXD followed by THP arm with 11% more, and the difference is there in the hormone receptor positive on a lower level and the hormone receptor negative population with 67 versus 83%. And here we have the TDXD alone arm resulting in a 43% PCR rate, and again lower in the hormone receptor positive than in the hormone receptor negative subpopulation for the completeness. The EFS of both groups on the right side, very early data showing a trend for an improved outcome with TDXD followed by THP versus dose-dense AC THP, and on the right side the TDXD versus the control arm shows overlapping early EFS curves. Safety in this neoadjuvant study where the patients received only 4 cycles of TDXD, slightly different to what we see, but in general, overall, not very much different. And this is They combined the grade 3 and higher toxicities and did not split the grade 1 to 2. In the DESTINY-Breast05 study, we split all the grades from grade 1 to 5, so you have a more complete picture on the safety there. But what was interesting, that patients with dose-dense AC also had ILD, which is here not on the list because this is the AEs over 20%. And again, nausea and vomiting is the most common, alopecia in 40% of the patients, which is identical in all three treatment groups, but neutropenia is the same and is higher in the dose-dense AC arm as expected. So when we compare the DESTINY-Breast11 study to other studies, I know we shouldn't do cross-trial comparisons, but we always do that because it's so interesting and we are so curious. We have seen quite interesting data and very high PCR rates also in other studies, especially in the studies where a long treatment, like in the TRAIN2 study with 9 cycles of T-carbo-HP was given, or FEC, 3 cycles followed by 6 cycles T-carbo-HP, which is certainly not a standard, but they also had in the hormone receptor negative population an 84% PCR rate, and this was also seen in the Geparceptor study with nab-paclitaxel. And on the left side, we have the more decreased approaches with the NeoCarb study with 6 cycles and THP in the Helen study, which showed in a different population similar PCR rates. So we know that the PCR correlates with the hormone receptor status, it correlates with the tumor size, and it correlates with the treatment duration. And of course, what do we want? Do we want to maximize the PCR rates? Can we really increase the PCR rates, or have we reached a ceiling here? These are open questions. And with that, I thank you for the first part, and we now go to the discussion, which is moderated by Joyce.
Awesome. Thank you. That's fabulous data and great discussion, great presentation. So we have some, I think we have a, I just wanted to just summarize a couple of things that came out today. Professor Corigliano updated us on some data from DESTINY-Breast11 showing that the safety profile with the T-DXd THP was very manageable and less toxic overall, looking at all of the PRO data, and specifically that physical functioning was maintained or improved compared to dose-dense AC THP, so that is good. And there's a lower patient-reported treatment burden with the T-DXd THP versus the AC THP. And then in DESTINY-Breast09, PRO data were also updated, and we saw that patients reported maintained or improved physical functioning with the T-DXd and pertuzumab, and they were similarly tolerated, even though in the Cleopatra regimen, patients stopped the taxane and continued the HP. Actually, when you look at the PRO data, they were very similar, with patients maintaining their overall time to deterioration of quality of life, et cetera. So there really wasn't a difference between them. So that was good. They're reassuring PRO. So we have a couple of case scenarios that we want to discuss. Let me just describe this patient here to you, Anna. She is 68, originally diagnosed with a 1.3 centimeter node negative invasive breast cancer. She was triple positive. This was 4 years ago. Breast conserving surgery, lost to follow-up, did not receive radiation nor any systemic therapy. Then she developed abdominal fullness, right upper quadrant pain, fatigue, and in the ER imaging showed an 18 centimeter liver with multiple solid mets, and liver enzymes were threefold elevated. Biopsy showed the same cancer, triple positive, and baseline brain MRI was negative. So that is her story, threefold elevated on the LFTs, totally untreated. So let's discuss What treatment option would each of you recommend for this patient? So let me start with you there, Sibylle.
Well, this is a patient who has not received any systemic treatments. He's basically like a de novo metastatic breast cancer patient treatment therapy. Now, if she has liver mets, most obviously, and I would start her on TDXD plus P.
And would you at some point add endocrine therapy? Would you at some point switch over to any kind of a maintenance strategy?
Probably I would, even if that was not the plan in the study. But we know if a patient responds and then we put them on maintenance therapy, we can actually keep them very long on this treatment regimen, longer than when we would not have a real good maintenance strategy. And we have seen here at the meeting additional data for maintenance strategies.
Mm-hmm. Thank you. How about you, Paolo? What would your approach be?
Yeah, I totally agree. This patient with visceral metastasis with elevated LFTs really requires a rapid response. I think right now the combination that we have that provides the best response rate, especially complete response rate, as we have seen, is TDXD pertuzumab. And we're waiting to see the TDXD alone arm from DB09 to see if it's equivalent or less or more active. And I agree that at a certain point I would consider a switch to a maintenance strategy. And I think, we don't know exactly when is the right moment. I don't feel that that moment is identical to Cleopatra, just because in Cleopatra it was dictated by peripheral neuropathy, whereas TDXD does not have that issue. And so provides, I think, more flexibility to adapt the duration of treatment to the patient tolerability, to the degree of response you see. And so I think at a certain point I would consider switching to maintenance. And at this point, after this San Antonio conference, we have two maintenance strategies that have shown improved outcomes, and these are the PATINA regimen, endocrine therapy, palbociclib, trastuzumab, pertuzumab, or the HER2-CLIMB-05 regimen, tucatinib, trastuzumab, pertuzumab, endocrine therapy. And I would like to stress endocrine therapy, because not all the patients on HER2-CLIMB-05 receive that, and we know how important it is to include maintenance endocrine therapy. In this scenario, I would favor the PATINA regimen, mostly because palbo seemed to be better tolerated. Tucatinib also was well tolerated, but PATINA seemed to be associated with very favorable tolerability and very long progression-free survival, 44 months, really impressive. I think we reached a really promising outcomes in the first line, and so I think TDXD pertuzumab induction, PATINA maintenance, this patient hopefully will do very well.
Thank you. And Javi?
We say in Spain, amen. I think it's difficult to add anything to what has been said before. Maybe two quick comments. The first one is that I am not a big fan of TDXD plus pertuzumab compared with TDXD alone. So I know that we are waiting to see the data of TDXD alone, but TDM1 plus pertuzumab is not superior to TDM1. I know that Destiny Breast 07, there is small improvements in overall response rate, but it's slight improvement. I don't think that we are going to have a significant effect of adding pertuzumab there. And last but not least, I think that PATINA or HER2-CLIMB is great after taxane-based therapy. But we do not know if the same effect is something with such a great drug as TDXD. Maybe the effect is so powerful that adding PATINA or adding HER2-CLIMB-5 on top of the maintenance will not add anything. So in the meantime, I think the feeling is good, but I feel comfortable with TDXD, again, with or without pertuzumab, let's see, for a significant number of cycles, and afterwards I would continue with HP only.
Maybe I can add some. I think it depends very much on the tolerability of the drug. And how the patients feel, and if the patient has responded well, and if you have the feeling that there is a continuous response to the treatment before we change, maybe we might add some endocrine treatment. A couple of patients received endocrine treatment in the Destiny Breast 09 study, but far less than could have received the endocrine therapy.
Yeah, I will say, fortunately, there are some people that see the future already. And so a couple of years ago, fortunately, Dr. Cortez and colleagues started a maintenance trial, starting with TDXD, and then moving to maintenance Demeter, that we're also running at Dana-Farber. Hopefully, we'll see some results in the future that will help us in this setting.
Yeah, that'll be very helpful data. So let's switch to the curative setting. We have this patient who's Lynn, age 38, 7-centimeter disease, 2 palpable axillary lymph nodes. PET shows subpectoral axillary nodes in the breast mass, no metastatic disease. And she has ER/PR negative, HER2 amplified, stage 3 early breast cancer. So let me start with Javi this time. Now, this is assuming now everything's available, it's on the guidelines, etc. How would you like to treat this patient?
Well, I think that, I have heard many things about what is best, to try to optimize the pathological remission from the very beginning, or to have the opportunity for DESTINY-Breast5 afterwards. I want to cure the patients from the very first time. So I would be in favor of going for DESTINY-Breast11 here. I think that the possibility to have a pathological remission is huge. And I think that's the best strategy we can offer to this patient. So DESTINY-Breast11.
And what do you think, Paulo? And then what if she has residual disease if you chose the DESTINY-Breast11 strategy?
Oh, I won the hardest question of the night. So I think that's really the place where we have the least amount of data, because the patient has received at this point THP, TXT, residual disease. What do you do? We don't know. I think in our mind, there's a chance that more than 4 cycles of TDXT may be needed there. At the same time, the disease is refractory to neoadjuvant TDXT, and so in the adjuvant setting, I think it is reasonable to consider still TDM1. And we know that from DB03 that TDM1 can still work after TDXT. And at the same time, for patients with high burden of residual disease at surgery after taxane, trastuzumab, pertuzumab, TDXT, probably may benefit from more chemotherapy. We don't love anthracyclines, but for those patients with high burden of residual disease, 4 cycles of AC may be still helpful. And finally, we still have neratinib for some selected patients with triple positive disease, very high risk, very motivation, and that do well. Some patients will experience diarrhea, some will tolerate, and so I think we have a large array of tools, and we have to think of all of them.
Thank you. And one question that's come in here, Sibylla, if you could maybe mention this. The control arm here was ACTHP. What do you think that, comparing a TDXD, THP versus a TCHP, do you feel comfortable that the DESTINY-Breast11 regimen would still be superior to a TCHP?
Well, this is also looking into the glass bowl. We don't know that. Overall, TCHP and AC followed by THP were identical in the PCR as in the Trifina study, if I remember correctly. But from the Trifina study, we also have the data that we can combine the anthracyclines with HP. So in these very high-risk patients, when we decide to go with an anthracycline, then we combine that with anti-HER2 therapy, because we should not wait, and this is the problem. You wait with the anti-HER2 therapy for another 12 weeks. This I would certainly not do in such a patient, which we have here.
Just a very quick comment. I do not understand really the debate about if the control was appropriate. To be honest, we agree that TCHP could be better in terms of toxicity. We can avoid this leukemia, cardiotoxicity, but there is not a single study that has shown that TCHP could be just numerically superior to ACTHP. I think ACTHP was a terrific control arm, also TCHP, any of them. And if we would have used TCHP, the question would be, why not anthracyclines? So I think that we are not happy with anything always. Great trial design, great results, and great standard of care, both DESTINY-Breast5 and DESTINY-Breast11, in my opinion.
Totally. I agree, totally. I think that's very, very clear. Well, thank you, guys. I think we hit on the key next steps for patients here, but over to Paulo here.
All right, let's change page and talk about a very different disease, hormone receptor positive, HER2 low, ultra low, negative breast cancer. And if you ask me what was one of the greatest advancements in breast oncology over the past 5 years, I think it was taking what we learned in the HER2 positive disease and using it to improve outcomes for the largest, the most common subtype of breast cancer, that is hormone receptor positive HER2 negative disease. And why is this so important? Because Even just 5 years ago, the standard treatment of these patients with hormone receptor-positive metastatic disease would have been exhausting endocrine therapies and then moving to chemotherapies, sequential lines of chemotherapy, taxanes, capecitabine, eribulin. But what we know is that these chemotherapies do not work too well. The first-line chemotherapy provides, in the real world, about 7 months PFS, in clinical trials up to 8 months. But in truth, these 7 to 8 months rapidly become 4 up to 3 months in late lines, which really means we need something better for these patients. And that something better came with ADCs. ADCs are basically enhanced chemotherapy, chemotherapy that is better delivered to tumors, with many different and complex mechanisms of actions that we are unveiling in these days. And the good news is that we have several antibody-drug conjugates available to treat hormone receptor-positive HER2-negative breast cancer. We have trastuzumab deruxtecan, or TDXD, sacituzumab govitecan, or SG, and datopotamab deruxtecan, or dato-DXD. TDXD targets HER2, SG and dato-DXD targets TROP2. All of them deliver topoisomerase 1 inhibitors. And so one important thing to understand, and that helped us to treat patients better, was that HER2 negative is not so negative. So we call it HER2 negative because it lacks the amplification of the ERBB2 gene and the overexpression of HER2, but still there is some HER2 expression. That HER2 expression, in terms of immunohistochemistry, is either 2+ non-amplified, or 1+, or 0 with some minimal staining, what we call ultra-low now. And if you take all of these patients, among the HER2 negative cases, about 90%, 85 to 90%, have some HER2 staining, almost all of the tumors. And so this is very relevant because we can use this HER2 staining to deliver a highly potent chemotherapy with TDXD, for instance. And this was first proven in a trial that was presented at ASCO 2022, which led to a standing ovation at the time, that is DESTINY-Breast04. In this trial, patients with endocrine refractory and chemotherapy refractory hormone receptor-positive HER2-low metastatic breast cancer, and also a small subset of patients with triple-negative metastatic breast cancer, all of them with HER2-low disease were randomized to further chemotherapy or trastuzumab deruxtecan. Primary endpoint, progression-free survival in patients with hormone receptor-positive disease. And since the first presentation of the data, there was a major improvement in progression-free survival, which basically doubled from 5 to 10 months, and also in overall survival, which was improved by about 6 months. And this was present, this benefit, both in patients with hormone receptor-positive disease, but also when you added the 58 patients with triple-negative disease. Response rate was the same irrespective of hormone receptors, 50%, compared to only 15% with chemotherapy. So basically more than 3 times. And when you look at then the next trial that was conducted to further clarify this matter, DESTINY-Breast06, this further expanded our knowledge by changing 2 main things. Compared to DESTINY-Breast04, DESTINY-Breast06 tested TDXD in patients with hormone receptor-positive HER2-low and ultra-low disease. So 1+, 2+, but also 0+ with some staining. And among these patients, it tested TDXD compared to chemo immediately after exhausting endocrine therapy. So in a chemotherapy-naive population, patients were randomized to TDXD versus physician choice of chemo that could be capecitabine or a taxane, once again with the primary endpoint, progression-free survival in patients with HER2-low disease. The ultra-low cohort was exploratory. And when you look at the results of DESTINY-Breast06, you can see that progression-free survival in this first-line cytotoxic setting was improved from 8.1 months with chemotherapy to 13.2 months with TDXD. And overall survival, we're waiting for it to mature, but showed an early trend, favorable trend for TDXD. This was in the HER2-low population, but when you look at ultra-low, which is a population where we wouldn't have originally expected activity for TDXD, we're talking of HER2-0, and still there was 13.2 months PFS with T-DXd compared to chemotherapy, which showed 8.3 months, similar to HER2 low. So there really didn't seem to be a major difference in outcomes between HER2 low and ultra low, although the hazard ratio did favor HER2 low compared to ultra low. Overall survival, same positive trend compared to HER2 low. This led to the approval by the FDA of T-DXd for HER2 low and ultra low hormone receptor positive breast cancer immediately after exhausting endocrine therapies. When you look at biomarkers, and this is very relevant because we know that in this population there's several combination treatments that are available to target different pathways, so T-DXd was superior to chemotherapy across biomarker profiles in patients with PIK3CA mutations or wild type, in patients with ESR1 mutations or wild type, and there was this small but intriguing analysis looking at BRCA1 and 2, and patients that had mutations in BRCA1 and 2 seem to derive even more benefit from T-DXd, which makes some sense because it's a topoisomerase inhibitor that targets the DNA, and we know that these patients, these tumors, have troubles repairing the DNA because of the lack of BRCA, although it's a very small analysis. So for now, it's hypothesis generating. But the message is that T-DXd was effective and more effective than chemo across the board. Let's move on to see the data with TROP2 ADCs. And so first of all, HER2, validated biomarker. We have so many drugs against HER2. So why are we talking about TROP2 now? Because TROP2, as Dr. O'Shaughnessy was mentioning, is among those targets that are highly upregulated by cancers and much less by normal tissue. There is a differential expression. It's a surface marker present on the surface of tumor cells, and it internalizes. So if you target it, it will deliver inside of the cell the chemotherapy. It's overexpressed by many epithelial tumors, including hormone receptor positive and triple negative breast cancer. So TROPiCS-02 was the first phase 3 trial leading to the approval of a TROP2 ADC in this population. This was different from DESTINY-Breast04. First of all, because it included patients both with HER2 low and HER2 zero breast cancer, so all of the patients with hormone receptor positive HER2 negative breast cancer. And then because they were more highly pretreated patients. These patients had received endocrine therapy previously, CDK4/6 inhibitors, and 2 to 4 lines of chemotherapy, with a median of 3 lines of chemotherapy. Patients randomized to sacituzumab govitecan given on day 1 and day 8 every 21 days, compared to physician choice of chemotherapy, CAPE, vinorelbine, gemcitabine, or eribulin. And looking at the results, sacituzumab govitecan statistically improved progression-free survival from 4 months with chemo up to 5.5 months with sacituzumab govitecan. Overall survival was also improved by about 3 months with sacituzumab govitecan compared to chemotherapy in this highly pretreated setting. And sacituzumab govitecan in this study was both effective in patients with HER2 low and HER2 zero disease, as you may expect. HER2 expression did not impact the benefit of SG, so now we consider it in both populations. And so when you look at side effects, we have seen previously the side effects of T-DXd. SG is similar and different from T-DXd. Similar because it does deliver a topoisomerase inhibitor, and so it does cause some degree of fatigue, of nausea. Nausea is quite common, although it becomes less common if you use adequate prophylaxis, as we will see. But the main side effect of SG is actually neutropenia. We see about 70% of the patients having any grade neutropenia, about 50% having grade 3 or higher neutropenia with this drug, with some patients experiencing actually febrile neutropenia as well, about 5% of patients. Diarrhea is also quite common, and alopecia is seen in most of the patients with this drug. And so another trial, so I mentioned that TROPiCS-Breast02 was a late-line trial, so of course, after seeing positive result, one may have thought, what would happen if we took SG to an earlier line setting, more similar to DESTINY-Breast06, immediately after endocrine therapy. This was ASCENT-07. We just saw the results of this study at this conference, and this was a trial for patients with hormone receptor positive HER2 negative metastatic breast cancer that had received previously 2 lines of endocrine therapy or rapid progression on endocrine therapy, no prior chemotherapy, and so they were randomized to first-line cytotoxic with sacituzumab govitecan versus physician choice of chemo that could be capecitabine or a taxane. Primary endpoint, progression-free survival by Beaker. And when you look at the primary endpoint, there was no benefit with sacituzumab govitecan. PFS was 8.3 months with SG and 8.3 months with chemo, hazard ratio 0.85, no statistical difference, as you can see also from the PFS curves. There was a slight difference in the investigator-assessed progression-free survival, but in truth, it's hard to read into this since it was an open-label trial, and so we don't expect this drug to receive an approval, a label for this early-line treatment, and so SG remains an option for late-line treatment of hormone receptor-positive metastatic breast cancer. So I mentioned the toxicities with this agent, and I mentioned nausea and vomiting, and so it's important to use a 2 to 3 drug regimen for prophylaxis, and this really is effective at preventing nausea. For diarrhea, it's important to instruct the patient to utilize loperamide adequately, and there's other strategies that have been tested, but in truth, I feel the main side effect of SG to remember and to manage is neutropenia. We know that neutropenia can lead to febrile neutropenia, can be life-threatening. This is why for patients at risk for neutropenia, so highly pretreated, frail, older age, you may consider primary prophylaxis with prophylactic growth factors, long-acting after day 8, with or without also short-acting after day 1. There was also a trial, Primed, that tested this strategy and showed less neutropenia with the drug, and so I do feel it's worth considering primary prophylaxis to reduce the risk of severe neutropenia. Another TROP2 ADC tested in this population was datopotamab deruxtecan, which has got some similarities with T-DXd. It's got the same payload, DXd, but it targets TROP2, and this was tested in the TROPION-Breast01 phase 3 trial. Similar to DESTINY-Breast04, population of patients with hormone receptor-positive, HER2-negative breast cancer, all of the HER2-negative. These patients had received previously endocrine therapy and chemotherapy, 1 to 2 lines of chemo, a median of 1 prior line, randomized to Dato-DXd versus physician choice of chemotherapy, eribulin, vinorelbine, capecitabine, or gemcitabine. Primary endpoint, progression-free survival and overall survival. And when you look at the results of this trial, progression-free survival was met. Dato-DXd prolonged PFS from 4.9 months to 6.9 months, as a ratio 0.63 statistically significant, which led to the approval of this agent for chemotherapy refractory hormone receptor positive disease. Overall survival was not met. There was about 18 months of OS in both arms, and there is a suggestion that this may also be related to some crossover that was seen in the trial, and so more patients in the control arm received either T-DXd or SG after progression, and we know that this can impact the results of overall survival. Irrespective of this, this has been approved, and now we have 3 ADCs for this population of patients with hormone receptor-positive disease. And when you look at side effects, Dato-DXd is quite unique compared to T-DXd and SG because it does come with some nausea. It's important to use prophylaxis with 3 drug regimens, but it comes with less neutropenia, and it comes with 2 key side effects to remember. One is stomatitis, and so about half of the patients receiving this drug experience stomatitis, mostly low grade, and also ocular disorders, mostly dry eye. About 40% of patients have any grade ocular disorders, and this is why it's important, as we will see, to monitor this. And so talking of ocular disorders, ocular surface events, about 40% of patients experience this. It's important to suggest the patients to use daily artificial tears, avoid contact lenses, and to have them seen at baseline and regularly by an ophthalmologist to monitor the eyes. And for stomatitis instead, that it's even more common, it's important to suggest the patients to use daily prophylactic steroid-containing mouthwash, ideally 4 times a day, and this can really help to prevent and to reduce the risk of stomatitis, but also cryotherapy, which is a fancy way to say eating ice during the infusion seems to be associated with an improvement in the risk of stomatitis. So I mentioned we have 3 ADCs. How do we use them? Do we use them all together, one after the other in sequence? we are seeing that this may be associated with some cross-resistance. There is some real-world data. We published something this year, but there's many groups that have been looking at this. There seems to be some cross-resistance when you use one topo 1 ADC after the other, which doesn't mean we don't have to use them, because these patients do require treatment options, but it's worth considering also using chemotherapy and intercalating, kind of doing what we call the sandwich approach. After an ADC, you can consider chemo and still consider ADCs at progression. And so this is kind of trying to put everything together. I think hormone receptor positive HER2 negative metastatic breast cancer, we still want to treat these patients with endocrine therapy first. Most of the patients, CDK4/6 inhibitors, exhaust all the options we have of endocrine therapy, but when we feel that cytotoxic therapy is appropriate, I feel right now T-DXd is the most effective option we have, especially for patients with aggressive disease where there is the risk that the patients may not receive the most effective option after progression, because some patients get lost after progression. Capecitabine remains to me an option for patients with more indolent disease, with some advantages related to oral administration and less alopecia. And then at progression, now we have many options. We have T-DXd, Dato-DXd, sacituzumab govitecan, further chemo, and I think it's key to choose based on the side effect profile. Whenever all of them are available, try also, of course, to implement patient preferences. These are so key in this case. If a patient is living far away, the way of administration every 3 weeks may have an advantage compared to day 1 and day 8. If a patient had previously ILD, maybe sacituzumab govitecan may be safer. So it's important to tailor this type of treatments. If a clinical trial is available, I think it's always a good idea. And one thing to remember, if the patient has brain metastasis, ADCs are always a good choice because they seem to work better in patients with brain mets. That said, talking about patient preferences and patient impact of these therapies, there is no person from which we can learn this better than from patients. And so there is this initiative, PCDI, Patient-Centered Dosing Initiative, led by Julia Mayos, that is in this crowd, but also by GRASP in general, that looked at patients' experience with ADCs. This was an experience in patients with a diagnosis of metastatic breast cancer living in the US that received an FDA-approved ADC. And when you look at the participants, there were 170 participants that participated to this survey. Most of them were white, but also Black, Asian, and Hispanic patients were included. And when you look at what was reported by the patients, 82% reported bad side effects, 35% dose reductions, 15% had frequency reduction, 14% hospitalized, 77% required additional medications. I think this tells us that basically ADCs are very effective but have side effects. And so whenever we use ADCs, we do have to remember to optimize prophylaxis, optimize monitoring, optimize management, because only this way we can really keep the patients on highly effective therapies and improve outcomes for our patients. Thank you so much.
Awesome. Thank you so much. And thanks for the great algorithm and your thoughts about how to sandwich and sequence, et cetera. So let's just talk about this patient, June, age 58, no comorbidities. She has a history of stage 2 ER/PR positive, HER2 0, status post-surgery, ACT, radiation, AI for 5 years. 7 months later, she has right hip pain, lytic bone disease, liver disease. Biopsy shows ER/PR positive, HER2 still 0. Germline is negative. ctDNA shows PIK3CA wild type, and so she gets fulvestrant and a CDK4/6 inhibitor, only 8 months. Now she's got asymptomatic progression in bone and new liver lesion. ctDNA still shows no target. She gets capecitabine. Disease progresses again. ctDNA still no targets. Liver's rebiopsied, and her HER2 is still 0. So she, okay, that's a different scenario, I'm sorry. So Sibylla, what would you treat her with?
Well, since we're in an ADC session, she is relatively young, with 58 years. She has already received a CDK4/6 inhibitor. She has no targetable mutations, I think this, and received already capecitabine. and she had HER2 null disease, so she is not a candidate for TDXD, but she's a candidate for SG or Dato-DXD.
Right, and what would you do? Talk about toxicities and
I
schedule?
would talk about toxicity and schedule with her, and I have more experience with SG, probably would lean a little bit more towards SG. I mean, the data in advanced disease are both identical. I mean, we haven't seen overall survival for Dato-DXD yet, but I think one could give both drugs to the patient.
There'll be a good patient discussion, as
Yeah,
Paolo
it's important to have a patient discussion here.
Yeah. And I want to get Javi for the next scenario here. It's the same patient, it's the same history, except she's got HER2 1+ now. And you can comment on the last case if you have a preference there too. No, it's okay. I got one right here. So what would you do with this patient, and also if she was 0, Javi?
For me, it's quite clear here. For HER2 low, I would always, I would decide for TDXD. I think that we have great data in terms of PFS, great data in terms of overall response rate, and great data in terms of overall survival. For me, it's difficult, if not contraindication, to suggest that an anti-TROP2 antibody conjugate could overlap the activity and so for me, it's TDXD clearly.
Yeah, TXD. And the first patient too, any other comments on that, or would you the SG and the Dato-DXD?
Me or?
Yeah,
or,
you.
Or,
yeah.
I mean,
yeah.
Well, no, I think that we have to take into account everything. We have to take into account the 3 weekly, every day 1 and day 8. We have to take into account diarrhea, neutropenia, compared with eye disorders and stomatitis. And that's something that should be discussed carefully. I think that the good point here is that both drugs are available in the US, not in Europe, and both drugs are active. So I would feel comfortable with both of them. That's clearly something I would discuss with the patient. I cannot say A or B now.
Yeah. I will just say one clinical situation makes me trend toward a DXD ADC, and it's patients with brain metastasis. They are not extremely common in this setting, HR positive in early lines, but you do see some patients sometimes, and we have more data with TDXD and Dato-DXD compared to SG.
Thank you. Go ahead there, Javi.
Thanks, Joyce. I would like to give maybe some key messages from the triple-negative breast cancer. I would focus basically on anti-TROP2 antibody drug conjugates. I would not talk about TDXD, because the data we have basically are from an exploratory analysis. So could be good for selected patients, but maybe this is not the best option here. And I would not talk about anti-HER3 antibody drug conjugates. Also, we have some data coming from phase 2 studies. So I would focus in the anti-TROP2 antibody drug conjugates, just to highlight here the unmet need we are talking about. Unfortunately, the prognosis is very, very bad for the majority of these patients. About 70% or so of these tumors would not require immune checkpoint inhibitors because they do not express or overexpress, I don't know how to say, a PD-L1. And which is even worse, half of our patients will be unable to go or to receive a second-line treatment. So again, clearly an unmet need. So in the second line or beyond, third line or beyond, we have 3 great data, 2 randomized phase 2 studies from ACCME and from trastuzumab govitecan, and phase 2 data coming from Dato-DXD. So the ASCEND study, you all remember this data. Second line or beyond, third line or beyond for the majority of patients, trastuzumab govitecan was superior to chemotherapy. Overall response rate from 5 to 35%, clear improvement in PFS, clear improvement in overall survival, and in many countries, that's a drug which is available and reimbursed. We also have some data from ACTMT, again, an anti-TROP2 from MSD, basically in the similar patient population. Unfortunately, the majority of these patients come from China, so it was not a global study. Nevertheless, the data are, in my opinion, great. Look at the overall response rate in the range of 45% in heavily pretreated patient population. Also, nice improvement in progression-free survival and in overall survival. So both drugs, similar activity in terms of both PFS and overall survival. Small piece of data coming from the Tropium Pan-Tumor 01, and these are the data of the triple-negative breast cancer cohort. And you can see here very good data as well, with a progression-free survival, again, heavily pretreated patient population in the range of 7.3 months. So all of them, ZASI, ACTMT, and Dato-DXD showed important activity in heavily pretreated metastatic triple-negative breast cancer patients. So now, based on this data, let's move into the first-line setting. And we had, I think, a great ESMO this year with two key data coming from the sacituzumab govitecan and datopotamab deruxtecan, moving into the first line to randomized phase 3 studies. So ASCENT-03 basically did have 2 or 3 key comments compared with the TROPION-Breast02. Sacituzumab, ASCENT-03, sacituzumab govitecan versus chemotherapy, physician choice. Second, patients should or could be de novo metastatic TNBC, or patients who received treatment in the early breast cancer at least 6 months of treatment-free interval. This is important because in TROPION, patients could be treated without this interval. So here, remember, at least 6 months of treatment-free interval. And last but not least, these patients should not qualify for immune checkpoint inhibitors, whatever the reason is. The great majority because the tumor did not express PD-L1. Sacituzumab govitecan versus chemotherapy, according to the protocol, patients were able to cross to sacituzumab govitecan beyond progression. And primary endpoint was PFS by BCAR. So here you have the Q results, hazard ratio 0.62, and the median moved from roughly 7 months to 10 months, about 3 months to 0.8 months absolute improvement in progression-free survival. It's true that although, remember, patients were able to cross to sacituzumab govitecan beyond progression, 80% of patients who received second-line treatment received sacituzumab govitecan. We did not observe a signal for overall survival. These data are still mature. Nevertheless, survival at this time hazard ratio 0.98. So what about overall response rate? Very similar, basically identical, 46% with chemo, 48% with sacituzumab govitecan. Duration of response was better, 7 months with chemotherapy, 12 months roughly with sacituzumab govitecan. Adverse events, basically neutropenia and diarrhea, very similar to TROPICS-02, so I will not spend more time here. TROPION-Breast02 is a very similar study with 3 differences. It's datopotamab instead of sacituzumab. Second, 2 co-primary endpoints, PFS and survival. 3, patients should or could have received early breast cancer treatments, and we did not require any treatment-free interval. So if they relapse 1 month or 2 months after, these patients could be enrolled in this study, but there was a cap of 20% for patients who received treatment in the early breast cancer and progressed during the first year. 20% of these patients were treated like that. And the last comment I would like to highlight here is that in the control arm, we did not allow doublets or triplets. So only single agent chemotherapy was allowed here, compared with in the ASCENT-03 that either taxanes or carbogem was allowed. Results: clear improvement in progression-free survival, a delta of 5 months, which in my opinion for this patient population is something very relevant, hazard ratio 0.57, and the median PFS moved from, you can see here, more or less, about 5.6 months to 10.8 months. So very nice improvement in progression-free survival, and also an improvement in overall survival. And I don't remember in the PD-L1 negative population an improvement in overall survival in the last years. Correct me if I am wrong, at least in the first-line setting. So nice improvement, moving from 18.7 months median overall survival with chemotherapy to 23.7 months with a datopotamab DXd. Another important aspect is overall response rate was double compared with chemotherapy. Remember, chemotherapy here was monotherapy, and 20% of patients were treated with chemotherapy in the early breast cancer, which might explain differences in the control arm. Here it was 29% overall response rate. In the ASCENT was 46% with chemotherapy. However, with datopotamab deruxtecan, you can see here an overall response rate of 62%. Duration of response, very similar compared with ASCENT-03, more or less 7 months with chemotherapy, 12 months with datopotamab deruxtecan. What about toxicity? Paolo explained very nicely. Remember, basically eye disorders in the range of 47%, dry eye in the range of 24%, and stomatitis in the range more or less of 50+%. Here you can see a more detail of these grade 1, grade 2, and grade 3 adverse events. Again, eye disorders and stomatitis. Finally, if we have patients whose tumors do express PD-L1, CPS 10 or higher, the standard of care is at the current time chemotherapy and pembrolizumab. So what about ADCs plus pembrolizumab? ASCENT-04, explore trastuzumab govitecan plus pembro compared with chemo plus pembro. Again, crossover was allowed, and primary endpoint was progression-free survival, very good curves, hazard ratio 0.65, and the median PFS clearly moved from 7+ months to 11+ months. So about 3.2, more or less, improvement in progression-free survival. There is a trend in overall survival, but again, the data are immature at the time this data was presented. Overall response rate, similar. We were not so different, 53% and 60% with chemo and with trastuzumab plus pembrolizumab always, respectively, and the duration of response, 9 months with chemo pembro, 16 months with pembro. Very interesting, how to combine, how to optimize anti-TROP2 antibody drug conjugates, and there are now significant data that maybe combining these drugs with immune checkpoint inhibitors makes a lot of sense. Begonia was updated at ESMO. Impressive results, in my opinion. 2 different cohorts. All comers, the majority PD-L1 negative, and also and only PD-L1 positive. Look at here the overall response rate in the range of 80%, and median PFS in the range of 13, 14 months, more or less. So based on this data, there is an ongoing randomized phase 2 study, which is called Diamond, datopotamab deruxtecan, with or without durvalumab in the PD-L1 negative tumor patient population. So this trial is enrolling patients. Finally, ACCME, remember, we had beautiful data, randomized phase 3 study in the late line setting. We have data in the first line, small phase 2, but look at the beautiful data, PD-L1 positive or negative, the majority PD-L1 negative, ACCME alone, overall response rate 70% overall response rate, also very impressive in both PD-L1 negative and all comers, majority PD-L1 negative, and also very interesting in terms of progression-free survival in the range of 13 months. Amazing data with ACCME alone, without immune checkpoint inhibitors. Remember the toxicity of these drugs, anti-MDs, combination of the other ones, basically hematological, neutropenia and anemia, but also stomatitis. Finally, just to save 1 minute, these drugs are moving into the earlier lines. Both of them in triple negative, ACCME is being explored there. Also, datopotamab in the PD-L1 positive population with durvalumab or without durvalumab, and all these drugs, amazing clinical trials in both residual disease after neoadjuvant and also in the neoadjuvant setting in trying to optimize what we have now with the Keynote 522.
Thank you so much, Javi. Excellent, excellent. There was a question here that I wanted to just ask the panel. In the HR positive, we had a lot of questions that came in, but in the patients who are HR positive, HER2 negative, in the metastatic setting, we're trying to decide, we get some ADC options, either first line or second line. Does their prior duration of benefit from CDK4/6 inhibitors matter? Or do these drugs work kind of agnostic of the duration? What do you think, Javi?
Well, I think that my comment here, I think that the duration of on CDK4/6 inhibitors for me does not count to decide chemotherapy or antibody drug conjugate. It helped me to decide if I would go into the chemo world or into the endocrine therapy second line world. Together with the amount of disease and the performance status, for me, all these 3 aspects together will make me decide to go for chemotherapy or not. But if you look at the duration of CDK, the benefit in DESTINY is identical regardless if the duration of the CDK was less than a year or more than a year.
Thank you, thank you. And let's just go back to the triple negative since we have a couple of minutes at the end here. Paulo, your take on the first line TNBC for those you're not going to give immunotherapy to? Any comments if they were both available in practice, how you would differentiate?
So yeah, I think having two options is better than having one because it allows you to tailor based on the side effect profile, comorbidities. I do feel there are some differences in the response rate. It was higher with Dato-DXd. In the administration profile, once every 3 weeks is more comfortable. Overall survival, I don't think it can be interpreted because of the difference in crossover, but overall the PFS that was longer, I feel that Dato-DXd does come with a slight preference in my case, just because I feel the data were stronger. But once again, I think the most critical thing here is toxicity profile. It's very different. They are two TROP2 ADCs, but despite that, they cause very different toxicity profiles. So I think we start from there. We offer both ADCs whenever both of them are available. And so the only scenario where I really trend more toward Dato-DXd is brain mets. We did present at this conference some data with Dato-DXd in patients with leptomeningeal disease. This was a later line trial, but we saw in mostly HR-positive metastatic breast cancer with leptomeningeal disease, very nice activity, 30% intraocular response rate, and among patients that had no prior ADC, over 1 year of overall survival. So I think it's quite promising, and this is why in this population, I tend to prefer Dato-DXd, but when both are available, I think both are an option.
Mm-hmm. How about you? What do you think, Sibyl, if both were available?
Well, I think I completely adhere with Dr. Tarantino said, because I think we have both drugs available, and we need to discuss with the patient the toxicity profile. I have little experience with Dato-DXd. I was not participating in the trial, so with SG I have more experience. So I think this also factors into the decision. And I don't like stomatitis so much, and the eye toxicity in many patients, even when they are older or already taking glasses, so then they are also afraid of the eye toxicity. But I think this depends really on the patients and on the doctor's preference too.
Yeah, and I'll just give you my 2 cents. I think the results, efficacy-wise, are very similar between the two. The biggest difference is the difference in response rate. Honestly, I would like to see more detail on that. It depends on how many livers versus lungs you have. I mean, there's a lot of details in response rate. Response rate's important, but clinical benefit rate's also important. So that's a question mark in my mind. But with regard to delta on PFS hazard ratios, survival, agree, can't interpret. One crossed over, one does not. Duration of response, identical, 1 month, 1 year. I mean, I don't see a lot of difference, honestly, there. So I think they're both options, and I think it really does depend on your patient. I just think it depends on where their vulnerabilities lie. One of the other questions that came in is, what about UGT1A1 with these topoisomerase 1 inhibitors? What do you think, Paulo, on that? Do you think we should be checking for that, or?
Yeah, we know about 10% of patients have detrimental polymorphisms, UGT1A1, star28 homozygous. They experience more neutropenia and diarrhea. The label does not suggest to look at it, but in truth, what's happening is that current modern ctDNA assays, which we often do at baseline, tell you the UGT profile, and if the patient has a deleterious polymorphism, we start with a lower dose. It's not something that was tested in a trial, but I think we are oncologists, and sometimes we have to be a little artisanal. It's not common, only 1 out of 10 patients, but I think it's reasonable. If you're not already doing ctDNA, would I look at it? Not necessarily, but I think this may evolve in time with evolving evidence.
I totally agree with that. I do like now our FDA label and our own pathways actually do recommend prophylactic use of hematopoietic growth factors. And so we tend to use the pegfilgrastim. This is with the sacituzumab govitecan, of course, on day 8. But one doesn't have to. You could use the shorter acting, as was done in the PRIME trial with day 3, 4, and I think it was day 10, 11, 2 doses after each week. So I think that's a good a prudent strategy to do, and just that extra protection for patients. So we've really taken to doing that, just being careful. So, gosh, we could go on all evening, and I really appreciate everybody's attendance. I hope this has been useful. There's so much data coming at us these days. These are essential for me to hear to kind of reinforce it. So thank you all very, very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, GRASP. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated. To access all materials for this activity, visit peerview.com/PTK860.